Very good evening, one and all. On behalf of IMA Tirupur and Neuroscience Forum, cordially invite all the speakers, moderators, and participants for this wonderful CME on two topics. One is the women with epilepsy and pregnancy, and surgery for seizures. Today we have speaker Dr. Baskar. He's a neurologist from consultant of Kovai Medical Center, Coimbatore, and Dr. Malla Baskar from former head of the Department of Neurosurgery, NIMHANS, Bangalore. I request Dr. Rajesh Babu sir to welcome.
I welcome you all for today's CME, which is being conducted by the Neurosciences Forum and IMA AMS Tirupur wing. See, every month our main aim is to conduct one CME program for the PGs of the neurosciences, the neurophysicians and the neurosurgery PGs throughout the country. And every month we are having different topics based on the international days which are falling in that month. This month in November, we are having the National Epilepsy Day. That's why on 17th of the National Epilepsy Day, to commemorate that, we are conducting the CME for today program. And today we have our senior consultants, Professor Dr. P. Baskar sir, who is going to give a talk on women with epilepsy and pregnancy. He is a senior consultant neurologist from Kovai Medical Center, Coimbatore. I welcome you, Dr. Baskar sir. And at the same time, I like to welcome Professor Dr. Malla Bhaskara sir, the former professor and head of the Department of Neurosurgery in NIMHANS, Bangalore. Sir was held up in one of the traffic jams, it seems, and he will be joining shortly. But we have the first speaker, Dr. Baskar. Baskar sir, he can give the talk. So I like to introduce Dr. Baskar. Sir is a senior consultant neurophysician from Kovai Medical Center. Did his MBBS and MD General Medicine from Tanjore Medical College, and there worked for 2 years as lecturer in medicine in Raja Muthaiya Medical College in Annamala University. Then he joined Tamil Nadu Medical Service as assistant surgeon in 1991. And he did his DM Neurology in the famous Institute of Neurology, Madras Medical College, Chennai. He joined as a consultant neurologist in the Department of Neurology in Kovai Medical Center in the year 1992. His special areas of interest is in the field of acute brain stroke management, thrombolytic therapy, the chronic headaches, Botox therapy for the focal dystonia, and epilepsy. I welcome you, Dr. Baskar sir, for the lecture.
Thank you, Rajesh. Good evening. So it is nice to be in this webinar. Of course, I'm happy to talk to you, the postgraduates, the neurophysicians, and the neurosurgeons. And this November being an epilepsy month. And Rajesh Babu has requested me to talk something on epilepsy. Of course, epilepsy is a big topic. And 30 minutes, I want to do something good to the persons who are wasting at least 30 minutes listening to me. So I have taken a small topic, which I think it will be useful to you in your day-to-day practice, and it will be good to the patients who comes to you for treatment. Women with epilepsy is a special group. It's a special group. And when they become pregnant, they become much more special, need much more care. And what is the most important point when they become pregnant. When they become pregnant, they have the problem of giving drugs. So what drugs to give, what drugs should not be given, so that the child in the uterus do not get any congenital anomalies. So that comes to the smallest topic in this epilepsy, that is anti-seizure medications during pregnancy. So what, as a postgraduate student or as a physician, neurophysician or a neurosurgeon should know about the drugs you are supposed to prescribe, are supposed to follow, and somebody with woman with epilepsy become pregnant. So I'm going to give you very few points for you to understand, remember, and make it useful in your day-to-day practice. That's the first slide. That is anti-seizure medication during pregnancy. Very short topic. I'm going to give you only 15 or 16 slides, which will give you the salient point for you to remember. I'm not going to load you with knowledge. I'm not going to teach you. Why it is so important? Why I should bring this topic to this August audience? Two things. This is in-utero anti-seizure medication exposure leads to two different problems. Number one, the teratogenic major congenital malformation in the fetus. Number two, non-teratogenic adverse effects over the fetus. I tell you, these two things are not hypotheses. They are proved facts. Proved facts. That's why we are worried. That's why we are worried. What I mean by these MCM, major congenital malformations. Any congenital malformation in the fetus which needs medical intervention, surgical intervention, social intervention, we call it as major congenital malformations. To understand better, the usual one is number one, neural tube defects. Okay, so you get the meningocele, meningomyelocele, cardiac malformations, atrial receptor defects, ventricular septal defects, renal malformations, oral clefts, cleft palate, cleft lip. It has to be surgically corrected. Hypospadias, the urethra opens below the pelvis. So these are the major congenital malformations which will need surgical intervention when the child borns. So that's why we worried, and we don't want these congenital malformation occurs in our patient's fetus. What is the second one? So slightly different. The non-teratogenic adverse effects of anti-seizure medications. This is in the meta-analysis. A lot of people have found the children born to women with epilepsy are smaller when compared to children born to women without epilepsy. That is small for gestational age. That means these anti-seizure drug medications have some effect over the growth of the fetus in the uterus. Number two, they do have some effect over the neurodevelopment. That is, when the child borns, we always look into the mental development, motor development. When you look into the motor development, mental development in a child born to a woman with epilepsy who have taken anti-seizure medication, we have found there is a low verbal IQ in children who are born to women with epilepsy. So anti-seizure medication do have some effect over the IQ of the children. Autism spectrum disorder, you know that. Autism spectrum disorders, when compared to women without epilepsy, it is more common in children born to women with epilepsy. This is the non-teratogenic side effects of anti-seizure medication. These are the two complications we worry and we want to avoid. Do you think we can be able to avoid, reduce the risk? Of course. That is the basic behind this talk. Is it possible? How to reduce the risk? How to reduce the risk? Very simple. I usually give you 3 points to remember. Number one, or the most important one, pre-conception planning. Pre-conception planning, and you should plan it before the woman with epilepsy goes for a pregnancy. So whenever some woman with epilepsy come to me, I always tell them, you give me 1 year for me to understand your seizure. Give me 1 year to treat and make you seizure free for 1 year. Unless you don't throw a seizure for 1 year, I'll not give you a green signal to go for pregnancy. So my advice or my rule is, my patient should be seizure free for at least 1 year before I give a green signal for her to go for pregnancy. Why? That's a period I have enough time to choose the anti-seizure medication with the lowest risk. If she is on too many drugs, I'll warn out the drugs which will have higher risk. So I will choose the drugs which has the lowest risk to produce congenital malformations. Then I will find out the plasma level of that anti-seizure medication, find out the lowest therapeutic dose at which my anti-seizure medication control her seizure, and I will note it. That is the plasma level in which the drug can be given at the lowest dosage to control her seizure, and that's the point I will keep it throughout her pregnancy to control her seizure. So this gives me at least 1 year. So 1 year I will look into her. Then once I have controlled all her seizures and find out the therapeutic dosage of that drug, then I will give her a green signal for her to go for pregnancy. And 99% of the time, my patient will not have any problem. This is called preconceptional planning. So why we are being worrying? Is it really, it's a subjective matter or objective matter? It's really, we put into objective. A woman without epilepsy, do you think they are 0% risk-free? No. Even with a general population, that's a 2 to 3% chance of having congenital anomalies. But at any part of the time, do you or any obstetrician tell a patient that you have a 3% chance you will have a congenital anomalies to a general population? No. Only when they come to women with epilepsy, we always tell them, look, you have a double the chance to get congenital anomalies. Like women with epilepsy, the chance is 4 to 6% chance for congenital anomalies to occur in her. Okay. But I will always think it in the other way around. I am an optimistic man. I will tell my patients, of course, your obstetrician says you have a 4% chance to get a congenital anomaly in your fetus. But I will tell you, you have got a 96% chance to have a normal baby. So listen to me, take the drug and go for your pregnancy. That's the optimistic way to look into that one. Woman with epilepsy has got a 96% to 94% chance of having a normal baby. The final point is there are 20 to 25 anti-seizure medication or anti-convulsion drugs available. You don't have to worry about all the drugs. The newer drugs, anticonvulsant, has not been tried in pregnancy, so they never come into the picture when it comes to women with epilepsy. The older drugs, which has been in use for the last 2 to 3 decades, will be useful in this woman with epilepsy. And already all these data has put them into 3 risk category: group 1, group 2, group 3. Sodium valproate is the highest risk category, so don't use it. Simple. The intermediate risk category is phenobarbital, that's a gardinal, phenytoin sodium, that's a heptine, dilantin, topiramate. They comes in the intermediate risk. The last one is the lowest risk. You should use it. Lamotrigine, levetiracetam, carbamazepine. Lamotrigine and levetiracetam are broad spectrum anticonvulsant, can be used both in partial seizure, epileptic seizures, and generalized epileptic seizures. Carbamazepine can be used only in partial epileptic seizures. It will not be useful in primary generalized epileptic disorders. Okay. The most important thing, if I like you to remember, is the dose of the anti-seizure medication at the time of conception. That's what I said. For 1 year, I will try to find out the lowest dosage and I will allow her to go for pregnancy. So the higher the dose during conception, the higher the chance of having malformation. So at the lowest dosage, the conception, at the time of conception, the chance of getting a malformation is very, very low. Polypharmacy, this is the one you always worry, no? If somebody is having 3 drugs, 4 drugs, I know definitely she has got a more chance to have congenital anomalies in their fetus. So what to do? You cannot simply say polypharmacy, you make it into a monopharmacy, monotherapy. You must understand one thing. Why somebody is having 3 drugs for her seizures? Simply because she is having intractable seizures. Her seizures are not under control with 1 drug. So I add 2nd drug, not under control, I go for a 3rd drug. So only after adding 3 drugs, her seizures are under control. She is having an intractable seizures. If she is having an intractable seizure and if she want to have a baby, it's a difficult one. It's a difficult one. If that in that situation, what do we do? So in that situation, usually what I do is I always send this kind of people to a neurologist who do a workup for surgery. So these are the patients who will benefit from a surgery for their seizures. If there is a chance for her to go for surgery, and if she successfully undergo a surgery, the number of drugs she is going to need to control her seizure will come down drastically from 5 drugs to 1 drug. Then keep her on that 1 drug for 1 year. Then after 1 year, you give the green signal to go for pregnancy. That's a way to take care of these intractable epilepsy patients. Okay, this is people who are on polypharmacy. This is the usual questions my patients or sometimes my juniors used to ask. When people are taking so many drugs, why people are always finding fault with the anti-seizure medications? This is a fact. Of course, there are a lot of theories put forward why anti-seizure medication cause congenital anomalies in the fetus. Number one is free radicals produced by the anti-seizure medications cause cause injury to the DNA or the fetus, causing congenital anomalies. Now, if you don't understand what you mean by free radicals is, free radicals are molecules which lack one electron in their molecules, so they are unstable molecules. We have got molecules in our body called antioxidants. They supply this electron to this free radical, make them stable molecule, and they do not destroy the cell. If you don't have antioxidants in your body, and you don't supply the free electron needed for these free radicals make every molecule in the cell unstable, and they cause the death of the cell. This is called oxidative stress. So the anti-seizure medications cause increased free radical productions, produce an oxidative stress, produce a DNA abnormality causing fetal anomalies. That's theory number one. Theory number two is some fetuses have low or deficient epoxidate hydrolase. It's an enzyme which will destroy the free radical. If they are not working properly, the free radical get an upper hand and they get a free radical insult. The second theory. Third theory is somehow the fetuses have folic acid deficiency, and the people always blame the anti-seizure medication causing folic acid deficiency in the mother, in the fetus, and the folic acid leads to DNA problem and congenital anomaly. Because of this one, we give so much of importance to this one, folic acid supplementation. Everybody should understand whether it is a proved fact or unproved fact. Most of the people accept folic acid supplementation is a must in pregnancy. It do have some effect in preventing neural tube defect occurring in a fetus. Okay, so folic acid supplementation is one of the important points you have to remember when you treat women with epilepsy. But it is always given to everybody who become pregnant. The dosage, preconception, that before they get pregnant, if a woman with epilepsy comes to you, in addition to the anti-epileptic drugs you are prescribing, you have to give them folic acid. That is during the pre-pregnancy stage, it is enough you give 1 milligram. Some 0.4 milligram to 0.8 milligram is the book says, but 1 milligram, if you remember, that's good. So 1 milligram before pregnancy, preconception. But the woman with epilepsy become pregnant, you have to increase the dosage if she is taking anti-seizure medication from 1 milligram to 4 milligram per day. And this has to be given throughout the pregnancy. This has to be given throughout the pregnancy. So you should not stop it. So any woman with epilepsy with a childbearing potential comes to you, you have to give them anticonvulsant plus folic acid, because most of the pregnancies are unexpected, sudden. We do not know when your patients will become pregnant. So it should always be given along with anticonvulsant for all ladies who have a potential to become pregnant. Then the last one I like to remember is, or like to understand is, there is a important you have to understand it. You have to monitor the dosage of the anti-seizure medication in the pregnancy, because the anti-seizure medication dosage falls during pregnancy. That is, the plasma level of anti-seizure medication falls during pregnancy. As you said, you have got three reasons. Increased volume of distribution, because the lady adds up more weight to her body. Increased renal clearance of the anti-seizure medications. Increased hepatic metabolism of the anti-seizure medication. Everything leads to a fall in the anti-seizure medication below the therapeutic level, then the lady is going to throw a fits. So what you have to do is, you have to check the plasma level. You have to check the plasma level. The book says you have to check the plasma level of the anti-seizure medication you are giving every month once the patient becomes pregnant. But it's impractical because the patient who are pregnant never come to the neurologist every month. So I always encourage them to come at least once in the first trimester, then once in the second trimester, then once in the third trimester, and once in the postpartum. So usually I check it in the once first trimester, the second time in the second trimester, third time in the third trimester, and fourth time in the postpartum period. If the level has been lower than my expected plasma therapeutic level, I increase the dosage of the anti-seizure medications so that she don't have a relapse of the epilepsy. Sometimes if the patient throw a fits in between in the pregnancy, I know there's a fall in the plasma level, I check it that time. Or sometimes if the patient comes to you with drowsiness, diplopia, giddiness, and I suspect there's a drug toxicity, then I also check the plasma level, and if it's on the higher dosage, I reduce the dosage. Those are the times plasma level estimation of the anti-seizure medication throughout the pregnancy is very, very important. Postpartum period, everything will come down back to normal. So if you have raised the dosage during the pregnancy period, the patient will always have a toxicity. So you have to reduce the dosage in the postpartum period. That is 6 weeks after the postpartum. That is everything. This is the very important point I like everyone to understand, because you will always come into this kind of position. That is, some lady will, as a woman with epilepsy, who is taking some drugs, get pregnant, go to an obstetrician. The obstetrician sees the lady with anti-seizure medications. She don't like the drugs. She will tell the lady, go back to your neurologist, change the drug, come back to me. She will come to you. I am 2 months pregnant. I am taking these drugs. My obstetrician don't want this drug. Change the drug. Very, very peculiar situation. My answer is, number one, I do not change anti-seizure drug medication during an established pregnancy. My simple answer. Never change the anti-seizure medication. Some lady is taking for years together and she is pregnant and she has come to you after 3rd month of pregnancy or 4th month of pregnancy asking you to change the drug. The minute you trying to change the drugs, then she will throw a lot of convulsion and you will find it difficult to control it. The second point is most important. I like you to understand. What the second point saying is, the vulnerability to any teratogen exists in the first 9 weeks. That is, if at all the anti-seizure medication cause problem to the fetus, it does it in the first 9 weeks of gestation. That is, even before the lady knows that she is pregnant, the first month, 4 weeks, it must have caused all problems. Okay? So when she comes at the 2nd month, 8 weeks, already injury if it has done, it must have been done. Okay? So there is no point in changing the drugs after the 2nd month. I tell you, it's not easy to change one drug to another drug during pregnancy. For example, the patient is on valproate. You just take it valproate. The obstetrician want me to change it to lamotrigine. You know, to give lamotrigine, you cannot give it at the therapeutic level at the start. You start with 25 milligram lamotrigine, because if you give higher dosage, it is going to cause toxicity. You start with 25 milligram, 2 weeks later 30 to 50 milligram, then the way you have to build up. At least levetiracetam, you can give it at the higher dosage. But when you give levetiracetam, you do not know that Caesar will respond to levetiracetam or not. If it has been responsible to levetiracetam, the previous neurologist must have controlled her with the levetiracetam rather than with the sodium valproate. So don't take a risk if she is coming at 2 months. Probably you can reduce the sodium valproate dosage to less than 300 milligram per day and see whether her seizures are controlled and allow her to continue her pregnancy and wait for up to 5 months, then check for the anomaly scan. That's the only thing you can do it. Simply, if at all you have listened to my lecture, you just see this slide, memorize this slide, I'll be happy. 3 drugs, you can use it in your practice if a woman with epilepsy come to you. Lamotrigine, levetiracetam, carbamazepine. Lamotrigine, levetiracetam, carbamazepine. These are the 3 drugs in the list. You use it, you will not have much problem. That is it. If you can understand how to give anti-seizure medication for women with epilepsy during her pregnancy and managing her through her pregnancy, then I am satisfied I have taught you something useful in these 30 minutes. If at all you have some questions to ask in this particular topic, I am happy to answer you. Thank you. Thank you,
Thank
Rajesh.
you, Dr. Thank you, Dr. Baskar, sir. So I now request Dr. our second speaker, Dr. Malla Bhaskar Rao, sir. Naveen?
வணக்கம்.
Dr. Malla Bhaskar Rao, sir. Welcome, sir. Dr. Malla Bhaskar Rao is the professor and the former head department of the neurosurgery in NIMHANS, Bangalore, and former professor and additional to the Sri Chitra Tirunal Institute of Medical Sciences, Thiruvananthapuram, Kerala. He is a consultant neurosurgeon with over 30 years of experience, performed over 1,000 epilepsy surgical procedures. The president IEA, President-elect IES India, past President Indian Society of Stereotactic and Functional Neurosurgery, past Continental Vice President World Society of Stereotactic and Functional Neurosurgery. The member Stereotactic and Functional Neurosurgery Committee, WFNS, a member Epilepsy Surgery in Resources Poor Regions Task Force. Research grants Satyam, DST and DBT, Welcome Trust, SCRB, DRDO. He has more than 90 publications and awards. Younger Investigator Award, International League Against Epilepsy, Research Scholar Against Epilepsy in 1999, Senior Research Scholar Award, University of Melbourne, Australia 2000, Commonwealth Fellowship Award, Association of Commonwealth Universities, London, UK 2001, FRCS, Royal College of the Surgeons of England 2013. Dr. Malla Bhaskar Rao is a senior most professor who is very much interested in treating epilepsy by surgery. I welcome you, sir, for this lecture.
So, good evening to all of you. First of all, I'm thankful to Dr. Rajesh, Babu, Dr. Vikram, as well as their entire team for giving me an opportunity to speak to you today on few concepts and strategies in epilepsy surgery. And this is my outline. I'll give you an idea about adult human neurogenesis, a little bit about learning and memory, and then important concepts of epileptogenesis, and give you two examples of hippocampal sclerosis as well as focal cortical dysplasia, and then conclude. This is a very interesting number, 37.2 trillion. You must be wondering what is this number. This is our real bank balance. Hello. So this is our bank balance. This is the number of cells in our body. So these cells are born, they grow, they perform their job. When there is a damage due to injury, infection, during this presentation, I'll give you some concepts and strategies in epilepsy surgery. And this is my outline. So I'll speak about neurogenesis, little bit about learning and memory, epileptogenesis, and then I'll give you two examples of one of hippocampal sclerosis and another one of focal cortical dysplasia, and then conclude. So this is the number I was speaking, 37.2 trillion. Very interesting number. Actually, this is our real bank balance. So we are all endowed with 37.2 trillion cells in our body. These cells are born, they grow, they perform their function. And when there is a damage due to injury, infection, or a tumor, they repair themselves and then eventually give rise to new cells. Examples are skin, gut, and blood. Unfortunately, such a cell division is not happening in the brain and spinal cord. So Raymond Cahal got a Nobel Prize for his famous neuron doctrine about 100 years ago, saying that whatever cells we have in the brain and spinal cord, it is fixed. It will not increase, or progressively with aging, the cell number will come down, but no new cells are formed. And this is the number, 86 billion neurons in our brain. And most of these neurons, 69 billion, are located just in one structure, one part of the brain. And it will be very interesting to know what is this part which has got so much of population, neuronal population, almost 69 billion. Only 17 billion, 17 billion neurons are in rest of the brain, scattered all over except this part. Have you wondered what is this brain which has got so much neuronal density? That is the cerebellum, human cerebellum. Cerebellum has got 69 billion cells. Everything, cerebellum is like a teacher. Whatever mistakes are done by cerebrum, like a student, are corrected by the cerebellum. And also cerebellum keeps a copy of all the cerebral activities. In fact, much of things we do, either singing, dancing, music, or even surgery, or driving, cooking, everything is automated mostly because of the cerebellar function. It's very interesting to see how these cells learn the work which they do. This is an example of sea slug, and a lot of experiments were done on sea slug by touching the gill of the sea slug. Two types of responses were elicited. One is a very, very weak stimulus, gentle touch, which elicited very weak response. And whereas if there's a painful, strong stimulus, the stimulus went all the way up to the cell nucleus and then nucleus synthesized proteins to remember the strong stimulus, and then there is an alteration, synaptogenesis, to accommodate the protein which was synthesized, so that next time when there is a strong stimulus, the cell remembers. And also the mechanism of withdrawal to painful stimuli happens because of this mechanism. And for studying this learning and memory, Eric Kandel got a Nobel Prize in physiology and medicine almost 20 years ago. So the learning and memory and the adult neurogenesis, new formation of new neurons happens in the adult human brain in three anatomical territories. One is along the olfactory system, olfactory neurons, olfactory bulb, olfactory tract. Another one is the periventricular area, and the third one is the human hippocampus. Some of the elderly people following stroke, and follow some of the people, young people, even with head injury, with infections, they recover. Some of the recovery following neuronal damage is because of the production of new neurons, which happens mostly in the periventricular area. But today's topic is mostly confined to the hippocampus, the adult human neurogenesis happening in the hippocampus. So hippocampus, Joseph Klingler, who is a teacher of Ghazi Asargil, has maintained that human hippocampus is the most complex structure of all the nature. Big books were written on the role of human hippocampus. I'll just give you a very brief idea about this human hippocampus. So we have a paired structure. There are two hippocampi on either side of midbrain. So this is it's about 4 to 5 centimeter structure. 4 to 5 centimeter structure, like alphabet C, A, B, C. So this is the head of the hippocampus, and which is medial to lateral, and this is the body of the hippocampus, which is anterior posterior, and then this is the tail of the hippocampus, which is lateral to medial. This is 4 to 5 centimeters structure of the hippocampus. And hippocampus forms a very important function in learning and memory. If you divide the memory into registration, storage, and retrieval of the memory, the mechanism of converting all the short-term memory into long-term memory, it happens in the hippocampus. So hippocampus is very vital structure in learning and memory. I'm sure what all things you have done since morning to night. After you fall asleep in the night, these events are temporarily stored in your frontal lobes, in the front of the brain, frontal lobes. And during sleep, they'll be reverberating several times from frontal lobe, from parietal lobe, from occipital lobe. They come to temporal lobe through entorhinal cortex. They enter the hippocampus, and based on the need, the necessity, and the strength of the stimulus, the strong stimulus. I gave an example of Eric Kandel's experiment on learning and memory in sea slug. Like that, suppose you may see many vehicles crossing you when you're driving. But suppose if you see an accident, if you see a tiger on the road, something which can harm you, something, there is a threat to your life, or some adverse event, it will have a striking impact on the brain, and that sort of thing will be registered, and then will be retained in the brain. All this happens through the hippocampus, and then subsequently, once the hippocampus analyzes the data and then considers it as an important for your learning, memory, and survival, it it converts and then stores permanently in the brain. Of course, in their respective areas, like visual memory will be in the visual cortex, auditory memory will be in the auditory cortex, tactile memory will be in the tact sensory area. It goes to the respective areas, but this is the way hippocampus processes the memory. So for processing this sort of converting this sort of short-term memory to long-term, hippocampus has got a very unique architecture. Its predominant neurotransmitter is glutamate, and then you see this sort of this reverberating circuits going through various areas of hippocampus. For example, this conversion of short-term to long-term memory happens in the Amund's horn. Amund's horn is the CA1, CA2, CA3, CA4, and the dentate gyrus. This is the dentate gyrus. This dentate gyrus has got the function of episodic memory. That means today evening we attended this webinar. So you will remember the place, time, the occasion, all those things. All this is processed by the dentate gyrus. And the working memory, like for example, getting up and then walking and then having a cup of coffee, all this sort of where you kept your phone, your book, picking up things and all those things. All this working memory, this all in the subiculum. Subiculum is the part of the parahippocampal gyrus. So this sort of cyto architecture makes hippocampus vulnerable for epilepsy. So there are epileptogenesis is a process through which a normal hippocampus becomes hyperexcitable and epileptogenic because of various genetic predisposition in utero or birth trauma, perinatal or febrile seizures. Because of a number of factors, the normal network becomes hyper excitable and then eventually lead to epileptic network. So this is a very interesting paper which came in Lancet Neurology long back 22 years ago. How a normal brain following say a head injury or a brain infection or because of the tumor, how a normal brain becomes epileptic brain. So I believe there are young people in the audience, residents are there. So you pick up this Lancet Neurology paper and then read, you will understand why some people following head injury will not develop epilepsy, why some people develop drug sensitive epilepsy, and why some people develop severe uncontrolled epilepsy following various brain infections, brain tumors, and head injuries and all sorts of things, because innumerable number of factors will affect the individual, ultimately leading to the drug resistant epilepsy. So this is one of the most common causes of chronic drug resistant epilepsy in humans. This is the mesial temporal lobe epilepsy. You see, there is a genetic predisposition, and then febrile seizures, and there is initially people respond to medicines, and then families will consult if when the seizures recur, then they from physicians to pediatricians, they move on to neurologists, and then ultimately it takes nearly 20-25 years to become severe drug resistant epilepsy. Then only they come for to the comprehensive epilepsy programs to find out what is the cause of this drug resistant epilepsy and what sort of further management is required. And also there are so many mimics are there. For example, you all know that somebody has got a frontal lobe epilepsy or temporal lobe epilepsy. Even so-called temporal lobe epilepsy, So many similar conditions are there. For example, there is a mesial temporal lobe epilepsy. There is a lateral neocortical temporal lobe epilepsy. There is a temporopolar epilepsy. There is a orbitofrontal epilepsy. There is a occipital epilepsy. There is a insular epilepsy. There is a opercular epilepsy. All look similar. When you look at the patient, all look similar. EEG also may look similar. So there is a great amount of workup is required to identify people to find the source. Luckily, this video EEG came out of NASA research in 1950s and 60s. NASA has sent chimpanzees to the space, and to monitor their heart and brain, there are ECG and EEG electrodes were placed. So to monitor the chimpanzees. So UCLA in Los Angeles did the workup of all these initial thing, and then later in 80s it became available for civilian use. So the beauty of this video easy telemetry is that simultaneously you will know behavior and then electrical activity of the brain. Suppose when this lady, if there is a movement of the right upper limb, focal seizures involving right upper lobe, we can simultaneously look at her left motor cortex corresponding to the hand area and then see what is happening. So it's a time correlated electrical and behavioral correlates. That's the video you see. And in 70s, initially CT, subsequently magnetic resonance imaging became available. And then, of course, the surgically remediable lesional epilepsy syndromes were also identified. For example, here you can see the autopsy. On the left side, you can see the normal hippocampus. Right, there is a small shrunken sclerotic hippocampus. And left cellular density is normal. Here you can see at this H1, H2, H3, there is a loss of neurons. With H2, there is some preservation of neurons. And before CT scan and MRI were invented, this is how this condition used to be identified. You see the small temporal horn on the left side and enlarged temporal horn on the right side. And now it's so easy to identify this condition with MR imaging. You see normal size shape of the hippocampus here, and here you can see small shrunken hippocampus. And surgery, it's going on from 1930s, temporal lobe surgery, but in 50s, largely based on the epilepsy surgery initial failures, it was the role of hippocampus, amygdala, and uncus were identified, and they were included in the resective strategy. Now, this is the resection strategy. About 4 to 6 centimeter neocortex is resected, and lateral 2/3 of the amygdala and anterior 2/3 of the hippocampus are resected as a standard of surgery. And once this surgery is done, the outcome is really good. I mean, nearly 60% of people, the epilepsy is cured, and then another 20%, there is a substantial reduction in the seizures. You see, compared to the medical group, this is please note that the medical group means people with mesial temporal lobe epilepsy with mesial temporal sclerosis. Only 8% respond to continued medical management, and among them 60% will respond to surgical procedures. So these are the this is an outline of what sort of pathologies, what sort of anatomical territories the surgery is likely to cure or control epilepsy, and what sort of conditions where surgery has got a palliative role. Like, for example, cancer, some we can cure, some we can control, some we can give palliative care. Like that in epilepsy also, epilepsy surgery also. For example, people with hippocampal sclerosis, once the sclerosed hippocampus is removed, there's going to be excellent outcome, 70, 80, 90, nearly 100% also we can cure the epilepsy. Same thing with cavernoma, same thing with low-grade lesions, and to some extent with developmental malformations. Whereas in conditions like Lennox-Gastaut syndrome or West syndrome, we can only prevent falls and injuries by doing surgical procedures. So all these procedures, including the vagal nerve stimulator, deep brain stimulator, responsive stimulator, all will reduce the burden of epilepsy, but will not cure. So fortunately, in India, the epilepsy surgery started way back in 1950s. In fact, in 1950s and 60s, Dr. Ramamurthy at Chennai and Dr. Jacob Chandi at CMC Vellore, they started epilepsy surgery in 1950s and 60s. And because new drugs have come, phenytoin and carbamazepine, and because of the rampant use of surgical procedures, because of failures, surgery was literally stopped in 70s. And also because of these drugs, also people thought that no more surgery. But again in 80s and 90s, because of the video EEG telemetry, and because of the CT scan initially and then MRI subsequently, and more than these things, understanding the surgically remediable lesional epilepsy syndromes. That means you do surgery, you cure the patient. With that understanding, number of institutions in India started epilepsy surgery programs. I happened to get a historical opportunity to do the first epilepsy surgery following invention of MRI, video EEG, at Sri Chitra Tirunal Institute in mid 90s, and then over a period of time went on doing more than 1,000 surgeries at Sri Chitra, at NIMHANS, and then various centers in India and abroad. And simultaneously, after Sri Chitra, All India Institute and NIMHANS and other centers started the epilepsy surgery programs. Even with our initial experience with limited resources, was at par with established centers anywhere in the world. And the same trend is being continued at several centers, not only at Sri Chitra, AIMS, Delhi, and NIMHANS, and then other centers, even like-minded people, young neurologists and neurosurgeons. We went and then helped many other people across India to initiate epilepsy surgery programs. Now we have more than 60 epilepsy surgery centers in India, and we do more than 1,000 epilepsy surgeries per year across all these centers. But our aim is to at least make 100 epilepsy surgery centers over the next 10 years. In comparison, China has got 300 epilepsy surgery centers. So our population needs this, should benefit from this service. And I hope, I wish you will spread the word about the role of surgery for people with uncontrolled drug-resistant epilepsy. So these are all centers which started epilepsy surgery subsequently. I'll just show you an illustrative case how these things are done. This is a young engineering student who came to me with uncontrolled epilepsy. You see, when you look at her, see, this is a still image of a video of Seizure. So in this Seizure, you see there is a head and neck and eyes deviation to the left side. You look at you see the both the hands. So the left hand is at rest, whereas right hand there's a tonic dystonic posturing, and to some extent it's involving the right lower limb also. So the dystonic posturing of the right upper limb, it suggests right sided limbs, suggests that the left basal ganglia are involved in this dystonia of the upper limb, and left basal ganglia just above the left amygdala. So she had a seizure involving the left mesial temporal structures, which has propagated to amygdala and to globus pallidus to basal ganglia, leading to this sort of dystonia. So this is a very robust clinical feature of a left mesial temporal lobe seizure. And if you see the interictal EEG, you see the T1, T3. This T1, T3 is left temporal area. You see there is a phase reversal. Again, you see here T1, T3, T3, T5. There is a spike and wave pattern. In comparison, you see on the right side, this red is right and 2, 4, 6, they're all right, and blue is left, and 1, 3, 5, they're all left. This is the coding of standardization of the EEG. So odd numbers are left, even numbers are right, and color coding, of course, it's variable. Here it is blue is left, red is right. So there is a you see this continuous spiking in the left temporal lead. So clinically, she has got a left temporal lobe seizure. Interictal as well as ictal EEG is suggestive of left temporal seizures. And see, when you look at the MRI, this is the hippocampus, and this is the normal size and shape of the hippocampus. Whereas you see here on the left side, the left hippocampus, it is small, it is shrunken, and it is white. See, there is loss of neurons. That's why it became small, and it's white because of the intense gliosis inside the which involve the hippocampal gliosis and neuronal loss, leading to hippocampal sclerosis. So this is the most common substrate of chronic drug-resistant epilepsy. And neuropsychological evaluation showed that in this lady, there is a verbal memory impairment, visual memory on the right side, hippocampus. Verbal memory is on the left side. So verbal memory is impaired. So she's an ideal candidate for epilepsy surgery. And this is how she underwent surgery. So this is the resection of the left hippocampus and amygdala. You see, temporal neocortical resection was done. This is the temporal horn. I'm touching the temporal horn hippocampus. I'm touching the hippocampus, and this is the amygdala. Amygdala is a nucleus. Amygdala is a gray matter surrounded by the temporal stem white matter. You see, I'm removing the amygdala. This is the amygdala. Amygdala is like an almond, badam, almond-shaped structure. So I'm first removing the amygdala. And the next, this is I'm opening the choroidal fissure. See, I'm sure surgeons may find it interesting. The choroidal fissure, this is the fimbria the fornix. Choroidal fissure is the natural opening of extra ventricular and intraventricular spaces. Anterior choroidal artery enters the temporal horn through choroidal fissure and supplies the choroid plexus. So aneurysmal subarachnoid hemorrhage enters the temporal horn through this opening. So this is a natural opening, and this is the head of the hippocampus. This is the body of the hippocampus. It's about 4 to 5 centimeter structure. So I'm lifting the head from its floor, and this is the brainstem. This is the cerebral peduncle. After the choroidal fissure, the next most important structure to expose is the hippocampal sulcus. You see, this is the hippocampus. This is the fimbria the fornix. This is the dentate gyrus. It's like a teeth-like dentate gyrus. And then it's like I opened the hippocampus like a book. This is one part, hippocampus proper, and then I'm coagulating the blood supply to the hippocampus. These are all small arteries coming from the posterior cerebral artery. Very important. If young surgeons, without knowing the intricacies of the surgery, if they try to resect the hippocampus, then there can be injury to these vessels leading to hemiplegia. So now the other side of the hippocampus sulcus, this is the parahippocampal gyrus, which is being lifted from the base of the brain. So this is resting on the basal arachnoid. You see, this is now it's an en bloc en bloc resection of about 3.5 centimeters of the hippocampus. So young surgeons should learn how to remove the entire hippocampus as a single piece. Then only the pathologist can diagnose hippocampal sclerosis, and the diagnosis has got a prognostic significance, especially how long to continue the medicine, when to stop the medicine. All depends on the correct resection of the hippocampus and also subsequent establishment of the diagnosis also. Because if there is no hippocampal sclerosis, then we may have to continue medicines for lifelong, and there may be some other pathology which you have to look carefully. So once the en bloc resection is done, this is the uncus which is herniated. So uncal herniation is a very common finding in people with hippocampal sclerosis, suggesting that at birth, during home deliveries, during forceps deliveries, these people herniated. Many of them must have died. The survivors subsequently developed hippocampal sclerosis and chronic recurrent epilepsy. So this is the, you see, this is the herniated hippocampus, a herniated uncus, which is being resected from the base. This is what the cavity, this is the brainstem, cerebral peduncle, posterior cerebral artery, and anterior choroidal artery. This is the extent of resection in the MRI, and this is the pathology. You see the CA1, CA3, CA4, there is a loss of neurons, whereas in CA2, neurons are relatively preserved. So correct surgery, postoperative MRI showing extent of resection, and histopathology showing the classical picture of mesial temporal sclerosis. All these things have got a prognostic and predictive value. So I urge young surgeons not to fragment the hippocampus with CUSA and lose this important information. Also, hippocampus is like a gold mine for epilepsy research. So preserve all your specimens. So what we can achieve with hippocampal sclerosis, unfortunately, we cannot achieve same thing with extra hippocampal regions as well as extra hippocampal pathological substrates. For example, there is a cavernoma here, there's a tumor here, DNET, and there's a gliosis here following a boy with underwent surgery for tuberculoma and subsequently developed gliosis and then epilepsy, uncontrolled epilepsy due to gliosis. And here you see this is a very interesting substrate called focal cortical dysplasia. You can see the normal cortex and white matter everywhere, whereas here, starting from the ventricle all the way up to the cortex, it is a hyperintense signal, and then there's a transmantle sign. The same signal is extending through the white matter. This is an example of focal cortical dysplasia. Just to give you an idea, we have 86 billion neurons. All these neurons are developed around the periventricular area, and the neurons which are developed around the lateral ventricles, they move to the cortex all over. You see here the neuron is born here and then move to the cortex, and they move to the cortex and then become excitatory in nature. Whereas neurons which are around the third ventricle, basal ganglionic eminences, they become predominantly inhibitory neurons. And so this is an example of one of the malformations of cortical development. This is cortex. This is white matter. You see the cortex is about 4 to 6 millimeter thick, and then white matter. You see here there is a sharp demarcation, whereas here the cortical mantle is thick and there is very poor cortex and white matter demarcation. So this is the cortical focal cortical dysplasia. Of course, in histopathology, you will find giant dysmorphic neurons as well as balloon cells. This is very intrinsically epileptogenic tissue, most common substrate underlying drug-resistant epilepsy, especially among children. These are various types of malformations, and many of them I have operated along with my colleagues at NIMHANS. Bangalore. Now, I'll just show you very quickly few illustrative cases. This young boy, he came from Bangladesh. You see, because of his behavioral abnormality, family could not control him during seizures, so they made a case for him and put him on the case. You see, this is his seizure, which look at his face. See, see, suddenly the seizure has stopped. This is intense, intense behavioral. You see, you see, there's a intense fear. See, the event stopped. The event stopped. Suddenly, his behavior has changed. And this is what he has got. You see, on the right frontal lobe, you can see the cortex white matter differentiation. Whereas here, there is no clear demarcation between cortex and white matter. And then there are several hyperintense signals. So this is focal cortical dysplasia. And this is the ictal pattern. It easy in focal cortical dysplasia looks as if a person is having uh, continuous seizures, and this is the extent of resection. So he underwent left frontal craniotomy, and then entire the abnormal dysplastic cortex has been resected. You can see the this is the frontal horn, and this is the basal ganglia caudate, and this is uh, resection cavity, and the boy was unable to go to school and then have a normal childhood, now started going to school and then enjoying his childhood. That is the curative power of this resective surgery. This is a young man who had a large developmental malformation in the temporal lobe, demarcated by the large vein of Labe. He underwent resective surgery and achieved seizure cure. This is a DNET involving close to the central cortex. You see, compared to the adjacent brain, cortical vasculature is different. It is a softer lesion, and then he underwent resective surgery. This is a young lady who had a ganglioglioma involving the right from the cortex all the way up to the ventricle. So she underwent resective surgery and achieved a cure for epilepsy. All these procedures carry risks are there. Risks are related to the reason of the brain. For example, if you do occipital resection, there are going to be visual field defects. If you do large resections involving temporoparietal area, there will be visual field defects. And if there are large, if there are resections involving the central cortex, motor cortex, sensory cortex, there are going to be deficits. Similarly, if resections are going to be done close to the Broca's area and Wernicke's area, there can be language deficits. So fortunately, the risks of epilepsy surgery are not higher than the adverse effects of anti-seizure medication. So a lot of work goes into risk benefit evaluation during the pre-surgical workup. Only when there's a substantial benefit and minimal manageable risk, then only we contemplate surgery. And of course, pre-habilitation as well as rehabilitation plays a major role in surgical decision making. That's why it's a team decision involving number of healthcare providers and family to make a decision for epilepsy surgery. And so I mentioned during this presentation about neurogenesis, I mentioned about learning and memory, and I mentioned about epileptogenesis. I gave an example of hippocampal sclerosis, and I gave an example of one of the malformations of cortical development, that is the cortical dysplasia, and then I mentioned about the risk benefit of surgery. In a substantial number of these people, surgery cures epilepsy. In India, we take up people for surgery only when there is a assurance of cure or control to a large extent. Otherwise, we will not consider epilepsy surgery in India because of our limited resources. Now, coming back to you, we have more than 1.4 billion people, and these are all very conservative estimates of 5 million people. But according to latest reports, the number of people with epilepsy in India are 10 to 12 million, and about one third are drug resistant epilepsy, and it is again a conservative estimate of quarter million people who require surgery, but number is even a lot more than that. A quarter million Indians will need epilepsy surgery, but across 60 centers in India, only about 1,000 surgeries are being undertaken. So you are all like our ambassadors. When you see a person who is not responding to medicines, you should find out why they are not responding to medicines, and please refer them to centers, comprehensive epilepsy care programs, where the evaluation is done why they are not responding. Sometimes they may not have epilepsy, they may be having functional disorders. It's like a pseudo seizures. Suppose that if a child is under too much stress because of studies or parental pressure, may start throwing seizures. Or a woman, if they're asked to do a job or get married, they may have hysterical seizures. They're not real seizures. So all that workup, whether seizures are genuine or not, what type of seizures, what type of medication, what type of lifestyle changes are required, all these things are done, evaluated at a comprehensive epilepsy care programs. And a small number of people, when surgery is likely to cure their epilepsy, they are referred to surgery. And all of you can play a very important role in improving the quality of these people who are having a miserable experience in their life. And this is my email and my website, and then please feel free to reach me for any assistance. If you want to start a comprehensive epilepsy program, if you have a person who want to discuss further management, I'll be more than happy to assist you. And thank you very much for your attention. Thank you.
Sir.
Yeah,
Dr.
we
Aadhar
also
Sindhu Linkara.
enjoyed. I think I initially thought that two Baskars are too much, but I think it's good.
Aadhar Sindhu is there? Dr. Sindhu, sir?
Yes, sir. Sir is there, sir.
Dr.
Sir?
Sindhu, sir? Dr. Sindhu? Dr. Vikram has gone for a surgery, I think. That's why he is not there.
I see. Okay.
Praveen, you don't want to talk anything? Praveen? Okay.
Put message, sir, in the chat box.
So we have come to the end of our neurosciences forum
Sir, very,
for this
very
month,
informative lecture.
National Epilepsy Program Day. It was a very informative lecture, and first of all, I thank both the speakers, Dr. P. Baskar, the neurophysician, and Dr. Malla Bhaskara sir, for their nice lecture. And even Dr. Malla Bhaskara sir has told that he is very, very much willing to do surgery in any centers, provided the case and the theater. Thank you very much for your nice lecture, and even regarding this folic acid also, you have given some clues about how to do it as a project like this. In our country, we can also include the fortified folic acid food. From now onwards, we can try and do it, sir. So thank you so much for your nice lecture. Thank you one and all for joining this webinar. Thank you.
Thank you. Thank you.